Great. All right. Hello, everyone. Welcome. My name is Carissa Wengrovius, and I'll be the moderator for this webinar tonight. Thank you for joining us for the 11th webinar of the International Organization of Physiotherapists in Pediatrics, a specialty group of world physiotherapy. We're thrilled to have participants joining us from around the world today. So the title of today's session is Trauma-Informed Care in Pediatric Physical Therapy. We're honored to have two outstanding speakers on this topic, Dr. Jessica Barreca and Dr. Mary Swiggum from the United States.
A little bit more, and yeah. I guess I'd like to be just an open book and like, this is who I am.
I'm gonna mute you, sorry. Okay, so you'll see on your screen a link and QR code for today's webinar attendance form. Please take a moment now to complete this form. It's how we'll generate and send your certificate of attendance for continuing education purposes. We're also pleased to let you know that today's session is being recorded. The recording will be posted on our website and our YouTube channel, so you can rewatch or share with colleagues who couldn't attend live. Jessica, do you mind advancing to the next slide?
Sure, I can do that.
All right, so before we begin, I wanted to just draw your attention to our copyright disclaimer. This material has been produced and communicated to you by or on behalf of the IOPTP. The materials in this communication may be subject to copyright, so please refrain from copying or taking images or video footage of any material presented throughout this webinar. This helps protect the work of our presenters and ensures we can continue providing high quality content to you. So with that, it's my pleasure to hand things over to Dr. Barreca and Dr. Swiggum.
Thank you so much. All right, I'm going to advance to the next slide and let Mary take the next couple, and then we'll get introduce ourselves. Thank you so much.
So today we are going to be talking about trauma, abuse, and neglect. Please remember to self-monitor your own reactions to the content we are discussing. It is important that you prioritize your own self-care and take any breaks as you need. You all should have received the learning objectives. We will be reviewing what trauma, secondary traumatic stress, and retraumatization is. We'll be reviewing the signs of each, along with the principles of trauma-informed care. We hope that you leave with some actions that you can take with you and put into place in your practice tomorrow. So I am Mary Swiggum. I'm a physical therapist in pediatrics. I teach at Wingate University, which is outside of Charlotte in North Carolina in the United States.
Thanks, Mary. Hi, I'm Jessica Barreca. It's a pleasure to be here tonight and to talk to all of you. I'm a pediatric physical therapist as well, primarily have worked in early intervention and school settings, and did some work at higher ed at St. Louis University. And I'm currently, just as of a few months ago, took on an early childhood disability policy role at an organization called Start Early. So, with that being said, I did want to highlight one thing before we get started. Together with Mary, we were able to publish a special communication in the Pediatric Physical Therapy Journal last year about trauma-informed care as a standard precaution in pediatric PT. And so we're really thrilled to be here to talk about this with all of you tonight. I also just wanted to acknowledge Mary and I have had the pleasure of working in a community of practice with a few of the contributing authors that you see on this screen, Rachel, Bridget, and Caitlin. And then my colleague at St. Louis University, Kim, has also helped. We've done a number of presentations together, and we just wanted to acknowledge their contributions to this as well. So unfortunately, I did not get the poll questions sort of in here, but we just wanted to take a quick minute, say hello. We were able to introduce ourselves. So if you wouldn't mind just kind of putting in the chat where in the world you are joining us from, we would love to know a little bit more about you. So just take a moment and let us know where you are, maybe your area of practice as well. That would be great. And then in just a minute or so, I will advance to our next slide. Okay. So to start our presentation, we kind of always like to start and think for a few moments about what comes to your mind when you hear and think about the word trauma? Are there any specific images that come to mind, or what words do you really associate when you hear the term trauma? So in the PT profession, when we hear the word trauma, I think we often think of maybe a catastrophic injury, maybe a motor vehicle accident, maybe a significant brain injury, but we don't always necessarily think about those other types of trauma. So today we're going to discuss trauma and the science of trauma. But I think it's really important to note that there is not just one singular or universal definition for trauma. And so to define trauma for our presentation today, we're going to use the definition that was developed by the Substance Abuse and Mental Health Services Administration, also known as SAMHSA here in the United States. And they really use a 3 E's framework, which we'll delve into a little bit more on this next slide. So again, SAMHSA uses this concept of the 3 E's as a helpful way to kind of think about trauma. And so the first E is that event or circumstance that led to the trauma. So some examples of an event that could include experiencing physical or sexual abuse, childhood neglect, the experience of living in poverty, witnessing violence in your community or against a parent, or perhaps the experiences of wartime or experiencing a national disaster. And then experience is dependent on the perception of the individual. It's how that person assigns label or meaning to the event. And it really is dependent on what is that person's resilience? Do they have the ability to bounce back? Can they cope? What supports are in place? What kind of protective factors are really there in their life? And then the effects are very different. And they vary from person to person. And so the effects are the results of the person's experience of the event. And I always like to give an example, and I give the example oftentimes when I talk about the 3 E's of the difference of these effects based on event and experience. If you think about a car accident, let's say that 2 colleagues are leaving work and they both witness a horrific car accident at the end of a long day. It's Friday afternoon. One of those people who witnessed the event goes home. They talk to their partner, they connect with friends, they process the experience. They were horrified, but ultimately they're okay, and they don't really experience any of those lasting effects. The other person witnessed the same event, but they had a very different outcome. Let's say this person was recently themselves in a really terrible car accident. They live alone, they're new to town, they don't know many people, they really don't have a ton of social connections. They're not really able to process the event. So they stay home all weekend. When they get in the car to go to work on Monday, they have difficulty starting their car. This process continues to repeat itself over and over again. Every time they get into their car, and it really starts to impact their life. The person might not be able to drive to work. It might show up as impaired work performance, being late to events or to appointments, and lead to further social isolation. So 2 people saw the same event, but the effects were really different based on their experiences. Next, we're going to talk about types of trauma. So trauma can be classified as acute, chronic, or complex. Acute trauma is the trauma experienced from like one single particular event. Chronic trauma is prolonged trauma. It can be referred to as toxic stress. And toxic stress occurs when there's ongoing activation of your body's stress response system without supportive factors. And this leads to increased levels of cortisol, adrenaline, which then can lead, if unmitigated, to physiological changes in the anatomical structures of the developing brains and bodies of children. Complex trauma is the result of the long-term emotional and physical symptoms of unresolved stress. Unresolved toxic stress. And this is something we'll be talking about more throughout the presentation. Before we go on, I did want to pause and just kind of highlight another project that I worked on with an OT colleague of mine, but we really wanted to delve a little bit deeper and learn a little bit more about we wanted to do a survey to really describe the confidence, attitudes, barriers, and education of pediatric OTs and PTs regarding this concept of trauma-informed care. So we did end up doing a pilot survey of just about 90 OTs and PTs that work in pediatric settings across the US. And we asked them to rate their confidence and their attitudes and their educational experiences about trauma-informed care. What we found was interesting. We found that OTs really did report higher confidence in trauma-informed care when compared to PTs. And we did find that most participants did report favorable attitudes toward trauma-informed care. And we did not find a statistically significant difference between the two professions. Collectively, participants did report that lack of time and training were barriers to sort of implementing trauma-informed care. So again, this just provided sort of, again, a baseline knowledge, kind of filling that gap in the literature about what pediatric OTs and PTs are thinking about trauma-informed care, those attitudes, confidence, barriers, education. And so wanted to highlight that for everyone. Again, sorry, we don't have this poll about attitudes. But again, the full survey is in this study that I just shared with you if you're interested in the appendix, if you want to look at that. So wanted to talk now about the Adverse Childhood Experiences Study, or the ACEs study. You may have heard of this. This study took place almost 30 years ago now. But this is really the first study by Dr. Folletti and others that identified the impact of childhood trauma on the long-term health outcomes and overall well-being of people related to trauma. So this study took place in the mid-90s. It was part of this broader weight loss study. And what the researchers found were that there were some participants that were experiencing success. They were losing weight, but then they were also dropping out of the weight loss program. And they didn't really know why. So they did some follow-up interviews. And these interviews with these particular participants determined that their common experience was childhood sexual abuse. So participants stated that they initially had begun overeating to make themselves less attractive and therefore at less risk for sexual abuse when they were children. As adults, when they were enrolled in this weight loss study, they started losing weight. Their fears unfortunately resurfaced, and so they dropped out of the weight loss study. So this prompted the researchers to dig a little deeper. And they continued the study, and the researchers asked 17,000 participants about their exposure to trauma during the childhood years. And they found that there was a relationship between those adverse events that were experienced in childhood, such as abuse or neglect, or household dysfunction, and how those were related to long-term negative health and social outcomes across the lifespan. So on your screen, you see that there's the list of the 10 adverse experiences that were part of that original ACE questionnaire. So again, they were divided, these 10 ACEs were divided into 3 different areas. And as you see on your screen, participants were asked as part of this study to recall if they had experienced any of these 10 categories before the age of 18. Each category was given 1 point, and then the highest score a participant could receive was a 10. Obviously, this is in no way an exhaustive list, as it does not include a number of different adverse events, such as violence in the community, experiencing natural disasters, bullying, wartime or refugee experiences. And so just take a minute here to think of other adversity that maybe you're not seeing on these lists. So moving on, and we talked about this at the beginning, sort of that chronic trauma and stress, right? So we know stress is a normal part of development, and our body's stress response system kicks in during novel or stressful situations. This increases our heart rate, our blood flow, blood pressure, increased stress hormones like cortisol and adrenaline. I am the mom to 2 teenagers. My son is 15 and a half, and in the United States, that's when we start driving. I have very elevated stress responses every time I am with him and even look at a car. So, again, we all know what stress feels like, right? We know it's a normal, typical part of life. And when you think about it, the Center for the Developing Child at Harvard University outlined these types of stress, and they talked about it in the context of child development. So, a positive stress response. This is normal, it's essential, it's part of healthy development, right? We need to learn how to deal with stress, right? If a positive stress is maybe something like when a child goes to a daycare setting for the first time, or they meet a new babysitter, or they're getting an immunization, right? There's those brief increases in heart rate, mild elevations in hormone levels, right? It's a normal part of a child's experience. It's a part of everyday life, and the child is able to regulate these mild elevations in their heart rate, in blood flow, in those stress hormones, because they are being supported by a nurturing and caring adult. Next, we have those tolerable stress responses. This activates your body's stress response system to a greater degree, as it is a result of a more severe or longer lasting difficulty or adversity. This could be the loss of a loved one, a natural disaster, or a very frightening injury that a child experiences. The stress is tolerable, though, because the child has a supportive relationship with a nurturing adult who is providing that opportunity to learn how to cope and to really mitigate that stress response. So the child is able to learn how to cope with a scary or unexpected event, and they can bring their stress response system back to homeostasis. A toxic stress response can occur when a child experiences strong, frequent, or prolonged adversity. This could be sustained physical or emotional abuse, chronic neglect, living with a caregiver in a very unpredictable environment, that exposure to violence, or those accumulated burdens of poverty, without ongoing support from that nurturing, caring adult. So this prolonged activation disrupts how the brain and other organ systems are developing. And it really is associated with a long-term increase in risk for developmental delays and negative health, social, relational, and future life outcomes. However, it is important to know that the ACE score is a number. It provides a total of very specific traumatic experiences. We know that higher ACE scores are connected with poorer health and social outcomes at the population level. But ACE scores don't represent all types of trauma. They don't represent the frequency, chronicity, or severity of a child's trauma. It also doesn't take into account the very important protective factors and the strong, supportive, nurturing relationships that can exist to support a child's ability to build and utilize resilience. So ACE scores are not sort of a life sentence, and they don't predict individual health. We do know, though, that those higher number of ACEs, there's a higher risk for negative health behaviors and potential health outcomes. But again, it's established within the research that protective factors like positive parenting and those stable, supportive, nurturing relationships are so incredibly important to a child's ongoing development. So at this point, I'm going to turn it over to Mary.
Okay. So now that we have defined what trauma is, we're going to take a look at the principles of trauma-informed care. Trauma-informed care is a strength-based service delivery approach. It is grounded in the understanding of and responsiveness to the impact of trauma. It emphasizes safety, physical safety, psychological safety, and emotional safety. It creates opportunities for survivors to rebuild a sense of control and empowerment. There are many different models of trauma-informed care, but there are 4 basic elements, and they are represented here in the 4 R's. Realize the prevalence of trauma, recognize how trauma affects all, respond in ways that integrate knowledge about trauma into policies, procedures, and practices, and resist retraumatization. So we're going to start with the first R, realize. Trauma is rampant across the world. In the United States, we know approximately 2/3 of adults report at least one ACE. 1 in 6 report 4 or more. 1 in 10 children have experienced 3 or more ACEs. We know that exposure to trauma is increased in countries experiencing war, extreme poverty, extreme climate conditions. But it is important to remember what Jessica said early, in that trauma is an event, and how it is experienced is very different according to how that person's makeup is. Research does show that a person experiencing higher number of ACEs is more likely to have chronic health conditions, mental health illness, substance use disorders, risky health behaviors, and overall poor social outcomes. Each of those are listed here on the slide. Research has also shown that some groups are more likely to have experienced ACEs than others, such as Black, Hispanic, and Latino people, people with less education, people from lower socioeconomic backgrounds, people who are unemployed or unable to work, and lesbian, gay, bisexual, and transgender people. Trauma is especially harmful to the developing child. Children with 6 or more ACEs are 90 to 100% more likely to have cognitive, emotional, and language delays. Children with 4 or more ACEs are 32 times as likely to have a diagnosis of learning or behavioral problems. As pediatric physical therapists, we need to be aware that children with disabilities are at even greater risk to experience violence, abuse, and neglect, and domestic violence. There are some protective factors for youth that live in communities or countries with high rates of violence. They are listed here on this slide. There are some things that we as PTs can have influence over, such as what type of school environment is available to that child, what kind of community resources are available. It is important that we advocate for these children. We also know that displaced individuals, those fleeing events that are potentially traumatic, such as war, civil unrest, etc., are at higher risk of experiencing trauma and may lack the protective factors that help to buffer people from trauma, such as family, healthy community resources, access to clean food and water, and living conditions. People with disabilities who are displaced are at even higher risk for experiencing adversity and trauma. They have a harder time accessing humanitarian assistance, and they face inhumane detention centers that probably do not have the resources that they need. Survivors of torture experience higher levels of PTSD, depression, anxiety, and psychosis. Unaccompanied and separated children may experience delays in development and poor self-regulation skills due to the negative effects of trauma on their developing nervous system. Trauma can affect life expectancy. As you see here on this slide, people with 6 or more ACEs die 20 years earlier on average than those without. The next R of our 4 R's is to recognize. Sorry for the dog. Recognize the signs and symptoms of trauma in our patients, peers, families, and coworkers. Trauma can result in significant neurobiological effects that affect learning, development, and behavior. I want you to take a second to glance over all these neurobiological effects of trauma and consider how they may affect the children that you work with, their ability to learn new motor skills, their ability to cooperate, to pay attention in school, and to perform basic life skills. Okay. What trauma looks like in a child can vary depending on their developmental age. Infants may present as being very fussy and having poor self-regulation skills, poor eating and sleeping patterns, and even failure to thrive. Preschoolers may cry a lot, have excessive fears, stunted growth, poor sleeping and eating. We may see regression in potty training, in language, and their play may also demonstrate some of the trauma that they have been experiencing. The elementary school child may have fear, anxiety, display signs of shame and guilt. Again, we see problems with sleep and eating, concentration, and performance in school. The high school student may show all of those, but as we get into adolescence, we see now risk-taking behaviors, perhaps exploring with different kinds of substances that alter their minds and behaviors a little bit. Disordered eating, more along the lines of anorexia and bulimia, or perhaps excessive eating, and sexually promiscuous behaviors. I feel I have presented a lot of negative, very sad information, but I think it is important to realize how powerful resilience is. The presence of a loving adult who can help the child manage stress and emotions is one of the most powerful protective factors there is. Safe, stable, nurturing relationships can help the child buffer the toxic effects of trauma. We, as healthcare providers who tend to be a rather constant in our children's lives, can be that stable, safe, nurturing person. So I want you just to take a second to reflect upon the children that you have seen in your practice. Have they experienced trauma? Have you seen these signs of trauma? Were you able to be that safe, stable, nurturing person for them?
Yeah, and if anyone wanted to share any thoughts or had any questions, please feel free to kind of put them in the chat right here. We'll be happy to answer any questions that you have. Or if you wanted to share out any reflections as well. Okay. I'm going to keep going on. So as Mary kind of had alluded to, it is a lot of heavy information, especially when we're talking about the trauma that children have experienced, and also recognizing as a pediatric PTs, right, we're not only working with children, but we're also working with their caregivers and recognizing the trauma that perhaps parents and families and caregivers are bringing forth as well. And Mary's going to talk as well about some of how we can help support ourselves and our colleagues as well. So we're at today's part of today's presentation where we talk about how we can respond to trauma in a universal way. So unfortunately, right, when we are working with kids and families and students and our colleagues, they don't have a bubble above their head that kind of shows us their ACE score or their trauma history. But we know that if we take that universal precautions approach and we provide trauma-informed care to everyone, and we kind of use this lens of trauma awareness, that we can better support those we see and those that we work with as well. So some of you might have heard of Dr. Bruce Perry. He wrote a book with Oprah that we have a picture of it at the end, so you might have heard of him, but he's done a lot of work, a lot of research and work in the areas of trauma and trauma-informed care. And this quote really speaks to the importance of relationships. And another famous kind of just wonderful childhood advocate, Dr. Jack Shonkoff from the Harvard Center for the Developing Child, talks about how children develop in an environment of relationships. And as Mary said, the most important thing we can do for kids who are experiencing trauma is to be a supportive, nurturing person, consistent person in that child's life. Helping to model that for other adults and caregivers in their life is so important. But we can also help children learn how to cope with some of their trauma that they're experiencing. I think sometimes we underestimate the significant amount of time and consistent presence that we offer children that we see. And so we really want to emphasize the importance of being that supportive adult in a child's life and modeling positive parenting practices and nurturing support for kids. So we talked about this, right? What is trauma-informed care? It's really the strengths-based approach. So how do we respond, in a trauma-informed way? I think it's really important to know, I first heard the term trauma-informed care back in 2014, and I've been thinking about it, studying about it, reading about it for a long time. And I'm still on my journey, right? And so I think that it's really important to first recognize sort of like the presence of trauma and how it exists in our world, and acknowledge that trauma can impact a person's life through development and across the life course. And then recognize that trauma-informed care and how we respond is an ongoing journey for not only individual providers, but also for organizations. And it's really intended to meet people where they are. So we really are going to talk more about how we focus our efforts on ensuring safety and building choice and empowering our patients and families. And really it's about taking those intentional, deliberate steps to recognize that there are triggers that can potentially re-traumatize our patients. And how can we go about ways to really actively avoid re-traumatizing them? And then there's that emphasis on preventing secondary traumatic stress for ourselves as healthcare providers, and also supporting our colleagues as well. So the first thing you can do, if you take away, I think, like just one thing from today, this goes back to Dr. Bruce Perry's book, but again, this is sort of like that foundational piece that you start thinking about when you're thinking about trauma-informed care. And it's about changing the question. This is how we really begin to shift our perspective. The questions that you're going to see on this slide are part of that internal dialogue that you have when you're working with a family or a young child, or maybe your colleagues. And as we look at it through the lens of trauma-informed care, and we think about the prevalence and the tremendous impact that trauma has on a person's life, we can begin to shift our focus and not ask or think to ourselves when we're working with a patient and their family and think, what is wrong with you, right? But instead, take a minute, recognize that prevalence and impact of trauma, and think instead, what happened to you? And then what can I do to help you? And taking this approach allows us the opportunity to be more empathetic and just kind of like helps us reset ourselves. I really found that this was one of the most eye-opening aspects of my first trauma-informed care training. And it's really helped me personally move from a place that I wasn't necessarily proud of when I sometimes was doing more judgment than empathy, and moving to a place of more openness and working toward empowering patients and families. Okay, so again, we're going back to our friends from SAMHSA, but they really developed these 6 key principles to a trauma-informed care approach. And this requires shifts. We'll talk about this more, but at all levels of an organizational structure, right? If you are the most trauma-informed care PT ever, it's not going to help if you're part of a healthcare system where the parking lot attendant or the custodian or the receptionist or the CEO of the company doesn't also practice trauma-informed care, because it really does influence our patients' and families' behavior or experiences, of healthcare. So these are universally accepted principles of trauma-informed care. They might be worded a little bit differently, but this is typically what you'll see, and they might be applied a little bit differently across sectors. But the basic principles kind of remain the same. And so we'll go through each of those right now. So safety. It's really essential that we ensure our patients' physical and relational safety, right? So when you think about it, most of us can go about our daily lives believing we are safe from harm, or at like a minimum that we can predict our own risk for harm. But when we take a moment and think about it from a child's perspective, for kids who experience abuse, neglect, or some other form of trauma or adversity, what if that harm comes from your primary caregiver? Then who is supposed to keep you safe? This impacts how a child learns to view their relationships and determine who is safe or is not safe. And then this impacts how they're forming relationships into adulthood. Safety also goes beyond that immediate sort of physical safety and includes emotional, psychological, relational safety. So creating a safe space for all of our patients and for our families, their caregivers, requires special attention to that psychological safety. There are some points on this slide that can help us create a physical and psychologically safe environment in the clinics, hospitals, schools where we see our kids and families. So trust and transparency, right? Creating clear and transparent expectations with our patients, with our families, telling them about what our proposed interventions are, who's going to be providing the services, how that might change, how is the care going to be provided, and then following through on all of those pieces helps us build trust with our patients. And a patient-provider relationship, right, that therapeutic alliance is so important. We also know that in some cases, though, the healthcare provider is viewed as an authority figure. And again, when individuals have experienced abuse from another person who is supposed to keep them safe or who is a perceived authority figure, this can create that power imbalance that moves beyond childhood, right? And that person might not feel safe or trust others in those authority roles. People who have experienced trauma have difficulty forming trusting relationships. And as providers, it's important that we recognize that some of our patients might actually test our relationships because they've been hurt in the past by authority figures or the people that were supposed to keep them safe and care for them. I also like to say in this section that from my own experience in the healthcare system, I really come from a place where I assume that the healthcare professional, the nurse, the doctor, the pharmacist, the PT that I'm working with is acting in my best interest, or at very minimum is not actively fighting against my best interests. So I sort of operated under the assumption that the kids and families I was seeing knew that I was acting in their best interests. However, we know that this isn't always the case, and that oftentimes the patients we work with have had very poor experiences within a social service system, within a healthcare system, within an educational system, due to systemic inequities or discrimination or all other hosts of reasons, right? And then this can be generalized and impact their ability to form trusting relationships with us as healthcare providers moving forward. So again, I think it bears repeating. As providers, we know that importance of a therapeutic alliance with our patients. We also know that trust is built over time. We need to invest the time it takes to create a trusting relationship. And we know trust cannot be expected, but it has to be earned. So in a trauma-informed approach, we talk a lot about peer support, and it really speaks to the lived experience of those who have lived and experienced trauma. We know that trauma leads to feelings of isolation and hopelessness, and that often people feel disconnected. We know that relationships are fundamental to a child's development, And the positive relationships with adults and caregivers facilitate that resilience building, that ability to cope, that ability to heal. And so it's really important that we consider peer support in the context of our patients and families and even our colleagues. And so when we think about peer support, I always talk to my students when I'm teaching my pediatric seminar. I always tell them to think about how can we provide this peer support? What can we do to make sure that families who are living with a new diagnosis or families who are new to this country feel support from others that have experienced something maybe similar to them? And how can we make those connections with them, right? It's not enough to give a resource guide or tell them, hey, there's a support group over there. It's really about us helping foster those connections and doing that warm handoff to truly connect people and provide that peer support, because it can go a long way to decrease feelings of hopelessness and isolation. And then empowerment, voice, and choice. I don't think this is kind of a new concept for everyone, but we know that every time we offer a choice, we let our patients, their families know that they have a voice and that what they say will be respected. We need to recognize that kids are often told what to do and how to do it. So oftentimes they have a hard time believing that their choices and opinions matter. So just making sure that we are building in this opportunity for choice, not only because it's a good way to motivate kids, but also because we're letting them know that their voice is heard and we're recognizing their strengths. Collaboration is a really key point of trauma-informed care. Again, all of these principles really overlap with one another, but this principle recognizes and emphasizes, again, that importance of relationships, right? True partnership can level those power differentials, those imbalances that exist, and can create a stronger alliance with our kids, their families, and our colleagues, right? And so we know that this partnership is required for shared decision making. So how are we truly collaborating with our patients, with our families, with our colleagues? How are we collaborating across systems to really make sure that we are providing our families opportunities to bring about their voice and empower them to make changes and make those decisions in their own child's care. And then cultural humility. This principle really emphasizes our need to listen to and learn from people who come from different backgrounds. And so it's important to respect and recognize the importance of a person's culture, their background, their gender. Trauma-informed care is about respect, and it requires an intentional approach to do this. So this needs to start with addressing our own biases and our desire to be culturally aware. When we're not sure about what's correct to ask or to say, we need to do the research. We need to ask. And using this trauma-informed approach, we recognize that certain individuals and groups are at a higher risk of exposure to trauma. And Mary covered that really well. So again, it's just really part of this ongoing cultural humility and making sure that we are checking our own biases, our preconceptions, and that we're really practicing this with all of our patients and encouraging our colleagues, our teams, our departments to do the same. So those are the 6 principles. And I want you just to take 1 minute to think about these 3 questions. Really think about, because you're probably doing a lot of these, like how does trauma-informed care look in your setting of practice? Thinking about examples or ways that maybe you are doing this individually. Maybe someone on your team, or maybe your department, maybe your school, maybe your entire organization is really implementing trauma-informed care, and thinking about specific examples. And then think about ways that you could potentially do better as well. And just pause here for 1 minute. Again, if anyone wants to drop a quick note in the chat, that would be great. There are not, right or wrong answers here, and we're all learning. Like I said, trauma-informed care is a journey, so we always love to get any thoughts. All right, I'm going to go back to you, Mary.
Okay. So we're up to the fourth R, resist re-traumatization of patients and their families as they engage with us and with the healthcare system. Okay. And I think it's important to take a second to consider what the family looks like. We talked a lot about what a child who's experienced trauma may look like. But oftentimes a child who has experienced trauma also has caregivers who have experienced trauma. And some of our caregivers that get labeled as no-shows or non-compliant are actually survivors of trauma themselves. So it is really important to change how we are looking at those patients and families, not what's wrong with you, but what happened to you, and to try to show them empathy. A lot of our caregivers who are trauma survivors never experienced empathy in their own lives. And they have a hard time experiencing that from another adult. They have a hard time parenting their child. They have a hard time getting their life together sometimes. And that's what it can appear to us. It's like they don't have their life together. They don't have their stuff together, and maybe they don't care. And they actually may care very much. They just may lack some of the skills. So it's really important to show empathy to not only our children that we work with, but also to their families and even to our coworkers. We have no idea what kind of trauma experiences our coworkers have had. When I teach, I teach psychosocial and I teach trauma-informed care and psychosocial, and it's a private institution. The tuition is outrageous. And I am always floored by the number of ACEs that my students share with me in what appears to be middle class, well-to-do population of students. So we just don't know what kind of past trauma experiences anybody has had. So in order to resist re-traumatization, we really need to apply trauma-informed care universally. We may not see outward signs of trauma, but it may be there, and we may eventually see some behaviors that show it to us. We need to be intentional with our language, our word choices, not only with the patients and their families, but also with each other as we're talking about families with our coworkers. Because we can affect change in our coworkers by just helping them look at our families and children in a different way. And we need to find ways to build resilience with the children and families that we work with.
Okay, I'm going to go ahead to our next slide, and we have a video that
Yeah.
I'm hoping works. So I'm going to start it now, and if you don't hear anything, let me know.
Ready to level up your future? At Rockhurst University, you'll do more than earn a degree. With
Sorry
nationally
about the
ranked
ad.
programs to choose from, you'll sharpen your expertise
Skip.
and graduate.
Okay, here we go. Sorry about that.
constant
Sorry
reminders
about
of your moderate.
the ads there. So that I always find that a very powerful video to watch because it really does remind you that we don't know another person's experience. And so, when Mary and I first met and first started talking about sort of how we were drawn to this idea of trauma-informed care as a universal precaution, right? Just as though hand washing is a universal precaution that we use in all aspects, right? Can we use trauma-informed care as a universal precaution as well, right? Acknowledging that we don't know another person's experience. We don't know their trauma histories. And so if we do think about those 4 Rs, if we do think about those 6 principles, how can we use this as a universal precaution? And I said this before, but I think it's really important to note because oftentimes people will say, well, how can I do this tomorrow? What can I do? And I think it's important to continue to become trauma aware, right? Realize, recognize, respond, and resist retraumatization, but also know that maybe we can be an agent of change on our team, within our, maybe not our entire organization, but maybe within our department, right? Because it really is important that everyone within an organization understands those 4 Rs and knows how to apply those 6 principles of trauma-informed care. If you are greeted by the receptionist with a sign that says, if you're late for an appointment or you miss 2 in a row, you will be considered non-compliant or you will owe $50 or all of those different pieces. Sometimes just a sign instead of saying welcome, right, can really turn our patients off, our families off. So again, thinking about at the organizational level, what are those policies? From an education component, right? You don't, although I think some of the pieces of trauma-informed care are really intuitive, it's really important that we have policies and we have professional development and we have education that is intentional about how we apply this within our particular organization, whether it's a school, a clinic, a hospital setting, within early intervention, all those different pieces. So thinking about that and making sure that everybody understands not only sort of the prevalence and impact of trauma, but also what is their role in building resilience, right? Helping people build resilience, helping people learn how to cope, those protective factors as well. So again, trauma-informed care is a journey, and it's great to be a trauma-informed care individual provider, but we also need to make sure that we're doing this with our teams, our departments, and our organizations as well. So just kind of thinking about that across. We're going to focus more on what we can do at the individual practice level right now. But again, we'll be talking, thinking about that more broadly. So this is part of a fact sheet that Mary and I and some others were part of. We created 2 fact sheets and we have links to them here and also links. We can put those in the chat later if that would be helpful. But we have foundations of trauma-informed care and then application of trauma-informed care to pediatric PT practice. And so I just wanted to highlight kind of, we did sort of like, what can you do as a PT in regards of planning the treatment and the evaluation. We did application of trauma-informed care to the ICF model, and then we also just identified some suggestions for organizing the PT visit using that trauma-informed care approach. So really wanted to highlight that and share that. This is available on Pediatric APTA under the resources sheets as well. Resist retraumatization. Mary talked about this, and I think, if we just wanted to highlight some things that you're probably already doing, but thinking about it in the context of how much our words matter, and how much our words matter not only to the children that we're seeing, but also how we're modeling how to use words in a way that resists retraumatizing people as a model for our students, right? If we're a CI. Or if we're modeling for colleagues or for parents and caregivers, grandparents, How can we use words in a way that's supportive and isn't triggering or traumatizing to our patients and families? I'm sure that any of you who have ever, worked with a PT student or maybe a student from another profession, oftentimes, working in a university, oftentimes they come back and they're like, you wouldn't believe what my CI said or what this physical therapist said, right? And I'm talking about when, you've all probably done it when we refer to people as their diagnosis, like, oh, there's a knee waiting over there, or, oh, there's a kid with CP and that in that room over there waiting for you. So again, just modeling how we can use language intentionally to be supportive and help our patients and families, I think is really important. Consider changing our language. Again, I worked in school districts for a long time or worked with a lot of different people, a lot of wonderful people who sometimes just didn't use language in the most supportive way, right? So instead of saying he, she, or is a bad kid, maybe we could model for our colleagues saying he or she is communicating their needs to me in the way that they have been taught, right? Thinking about that in a more trauma-informed way. Oh, that kid's just acting up. He just wants attention. Or maybe it's another way to say is like, yeah, I saw what they're doing. Maybe that's their way to ask for help, right? So just thinking about not only changing the question, but how can we change the language? And I think in our role as PTs, I think we're very good about this when we engage with the kids and parents we see, but also modeling for colleagues and other caregivers as well in a child's life is so important. Again, words matter. Different ways to communicate with kids. I think that, I think we talked to some of maybe colleagues from OT and speech about this too. Instead of be quiet, can you use a softer voice? Stop crying. It's okay to cry, right? Again, creating those safe spaces for kids. I like this one too. Instead of maybe saying you are okay to a child who's very upset, how are you feeling? Can you tell me how you're feeling? And just different ways to kind of engage and talk to kids is really important as an element of this trauma-informed care. And then resilience. We've talked about this throughout. The definition from SAMHSA is here on your screen: the ability of individuals, organizations, and communities to heal and promote recovery from trauma. And then there's also one from the American Psychological Association. And it's all about adapting, right, in the face of trauma or adversity. You might have seen, I do want to highlight, you may have heard of the like orchid versus the dandelion metaphor. But this metaphor really highlights how some people seem to be more like orchids, right? They're very sensitive to their environment. They need very specific temperature conditions, right? They need the right type of plant food. They need a very specific watering schedule, right? Versus those who are more like dandelions. And those dandelions, at least here in the US, I don't know if this is like a worldwide flower, they can grow anywhere, even if their environment is less than ideal, right? I saw one the other day growing out of a curb. And so I think it's really important to know that for some people, right, it is easier to adapt to stress and adversity, whereas others need more care and more particular environments. But again, how can we meet people where they are to do what they need? And then just highlighting an article that was published a few years ago in the New York Times about sort of this idea of makes some people more resilient than others, and kind of digging deeper into that resilience is really an interesting read if you're interested. Again, we wanted to highlight just a few other strategies that you might use. You're probably doing some of this already, but we know that one way to really help children feel kind of deal with those big feelings is helping them label the emotions that they feel. This is really an important component for social emotional development. And when children learn how to label and identify their feelings, they're better able to communicate how they feel. I started using this a few years ago. This is actually my daughter. I think she was 7. She's 13 now. But we know behavior is communication, right? And so I just took photos of her and asked her to give me her rendition of different feelings. And this is something I started doing with patients that I was seeing as well. Again, kind of figuring like, hey, I spent a lot of time, I'm this consistent, supportive adult presence in this child's life. What can I do to help them further build their social emotional skills? And then kind of ask them throughout our sessions. You can also use clip art if you're not able to take pictures. I also had little pictures of vegetables and fruits that had different faces that were identifying with emotion. If you want to take like culture, ethnicity, race, and gender out of it, it was a really cute set of things. But again, just helping kids label and identify emotions is a really important social emotional development tool that we can use. And then, we often use visual schedules to help kids communicate and understand routines, but we also might want to do this with more of the kids we see as a way to create intentionally, focus even more on that predictability and safety. We can also incorporate choice and voice and empowerment into these types of schedules. Helping kids manage their stress levels through different ways, like, right, we're really good at physical activity and games, and then also helping them build in opportunities for mindfulness, breathing activities can help them really start building and managing their self-regulation skills. And so again, we can model and embed these into our own sessions, helping kids better understand how to cope with some of those big feelings and give them some strategies to do that. And hopefully they can then generalize those outside of our sessions as well. So an important aspect of trauma-informed care is to resist retraumatization of not only our patients, but their families. Again, however, if you're the most trauma-informed PT, if the system you're working in doesn't uphold the principles, or if your team doesn't, it can be very difficult to do this. We know that stressful environments exist in the world of healthcare, educational systems, those social systems. And so again, what can we do? Really thinking about that from an individual level, a team level, and then that organizational level as well is so important. All right, I'm going to turn this over to you, Mary.
Okay, so we're moving on to secondary traumatic stress. We can experience secondary trauma when we are exposed to the trauma experiences of others. And this secondary trauma, it's not direct trauma, but it still can have tremendous impact on us as providers. And if it impacts us, it's going to ultimately impact the children and families that we work with. Secondary traumatic stress is not pretty. It can cause a lot of dysfunction in us as providers. We may feel like we don't want to go to work anymore. We may have a lot of anxiety about work. We may feel isolated from others. We may end up with sleeping and eating issues, just like the children do. We may adopt some unhealthy behaviors. Maybe we start feeling so bad, we start self-medicating with either alcohol or drugs. We may feel detached from other people, feelings of helplessness. And we may feel like, I just need a break. I need to get away from this profession. I know myself, I did experience this kind of midway in my career, working with very impoverished families and very ill children. And for me, a sign that I needed to do something was when I got another referral on a child who was terminally ill. And I actually felt sick to my stomach. And I was like, I cannot do this. I'm done. So it can impact us quite significantly. There are other terms out there, such as compassion fatigue and burnout. They're similar, but not exactly the same. Burnout can come from, high workloads, lack of support at the organizational level, where secondary traumatic stress is more when you really get a little bit overly emotionally affected by what your clients are going through, and you are not setting up a little bit of a protective boundary. Not that we're not going to get empathetic with our patients. We can have cognitive empathy with what they are going through, but we need to protect our own emotions and make sure that we have some healthy outlets to deal with them. So there's a little bit of a difference between the terms. And we do have a fact sheet on secondary traumatic stress coming out in the near future. So secondary traumatic stress It can lead to burnout as well. It can decrease team morale. It can result in poor staff retention and high turnover, which then costs our organizations more money because they have to train new employees. For our children, it can result in a lack of consistency of providers. And unfortunately, if we lose providers, we may also lose providers for our children. There's a lot of stuff you can do to help avert secondary traumatic stress. And one of them is just to try to find time for yourself to regulate in the moment. It's very hard to be traumatized by what you just went through with a patient and then go on to the next patient. And sometimes it just can build and build and build over time. Sometimes we ruminate on it and we just do not let it go. It keeps circling in our head. And that is just not a healthy response at all. We need to find ways to acknowledge it and let it go. And time for self-care is crucial. And I want you to think of what kind of activities could you do for yourself after a potentially upsetting visit with a child. If you only have a minute, like you're in the clinic environment, if you have 5 minutes, 10 minutes, or 30 minutes.
Yeah, and Mary, I think that's so important. I know this is something that I talk a lot about with students as well. And I think that it's so important for us to be modeling for our younger colleagues, or our other colleagues or students that we're, working with. How are we prioritizing self-care, right? And showing like it's okay, like, and we do have some upsetting situations, right? And we might just need to take a minute or take 5 minutes. And so what can we really do to make sure that we are taking the opportunity to regulate ourselves and kind of like process what we just experienced, I think is so important.
And having colleagues you can talk to is really crucial. Having a supportive work environment that appreciates the types of clients you're dealing with and what you are dealing with yourself is also crucial.
Yeah, and I think that that goes back to when you think about like organizational or even team trauma-informed care, right? Like you can be the most trauma-informed provider, but you still need your colleagues and you still need that organizational support. So sometimes when people are like, I don't really know what to do beyond my own trauma-informed, I always say, like think about a team meeting. Like what can you do with the team that you're immediately working with on a day-to-day basis, right? Can you create space where you're, building into maybe a weekly meeting where you just have the time to kind of like debrief and talk about potential self-care strategies, like share those ideas. I think can be a really good way to kind of like think about it and start framing it for the team approach.
Okay. So this is just a little self-care here. Think of one element in your own practice that supports trauma-informed care. Think of 2 compliments that you have received from a colleague, supervisor, patient, or family in the past few months. Think of 3 children who feel safe and made progress because of your work with them. And these last 2 can really just help you reset a little bit when you are in the deep throes of dealing with some traumatic experiences.
Yeah, and hopefully it's easy for everybody to kind of get there. I'm sure that it is.
Okay, so what can we do tomorrow? I hope you have a few tools to take with you as you go back to work tomorrow. Awareness, I hope, has improved. I hope that you can be aware that trauma is present everywhere. It may be present in anyone and everyone you encounter. You can foster healthy relationships and developmentally appropriate relationships between children and their caregiver. You can model for the caregiver how to have that relationship with their child. We can advocate for children and caregivers in our community. We may sometimes need to refer to providers when a child or a family really needs resources that are outside of our limits, and then intervene when necessary.
All right. And then just finally, as we wrap up, we did want to share some resources here. This is still up, Center for Disease Control, Adverse Childhood Experiences. They were they collaborated with Dr. Fletty and others in that original ACEs experience. And so this website provides a really nice repository of current and past research and just has some really patient-friendly handouts. So if you're looking just to kind of get a general overview of adverse childhood experiences, I suggest this for now. It's still there, so looking at that. One of the people, like if I could choose to meet one person in the world, I think it would be, hold on one sec, sorry. I think it would be Dr. Nadine Burke Harris. She wrote the book, The Deepest Well, really incredible textbook. She's a pediatrician by training. She has a wonderful TED Talk that I think everybody should be required to watch. So I think it's 16 minutes. So if you have time, either read her book or watch her TED Talk. Next, the American Academy of Pediatrics has some really good reports on trauma-informed care and then sort of like those PACEs, that positive childhood experiences and adult health outcomes. I think that these are two just really nice overviews, great references, resource list as well in both of those. And then, here's Dr. Bruce Perry and Oprah Winfrey's book, What Happened to You? This still has a lot of the research built into it, but it's written in a more conversational style. So if that's more your speed, you might want to check that out. And then there's also a wonderful textbook written by some OTs, written and edited, Trauma, Occupation, Participation, that Mary and I have both spent a lot of time with. So definitely a recommendation there. And then this is a new resource that I just came across through Children's Hospital of Philadelphia. Again, right, pediatric PT, when we think of trauma, we're a lot of times thinking about that injury. And this just provides a great deal of resources for parents, for kids, for professionals about all aspects of a traumatic injury. So I recently came across it, checked it out, so wanted to pass that on. And then finally, APTA pediatric resource sheets. So Mary and I have been part of a wonderful group of other pediatric PTs. We wrote the Foundation's Trauma-Informed Care and then that application as well. And as Mary mentioned, we hopefully will have secondary traumatic stress coming out in the next few months. That is all from us, but thank you so much for your time. It's really, Mary and I are very passionate about talking about this, so please feel free to reach out to either of us as we would love to continue to connect.
Jessica, there was a chat suggesting
Oh,
using
sorry.
characters from Inside Out.
Yeah,
Yeah,
That's
so
that's
cute.
great. Yeah.
Thank you both. This was a wonderful presentation and just a wealth of knowledge that you shared. So thank you. We do have a handful of minutes that if you are willing to take some questions,
Sure.
anyone can unmute if you feel comfortable or pop it into the chat box. If you have any questions for Dr. Barreca or Dr. Swiggum.
I know it is a lot of information that we throw at you. We try to like pare it down quite a bit. It's a heavy topic, I know. I did find that the first sort of trauma-informed care presentation I went to, I needed to let the information kind of marinate, and I had to process quite a bit. So I know Mary and I always talk about whenever we do this for students, we always say like, find someone to talk to about this in a couple days. If it's something that you like, if something surfaced for you or if you have further questions, again, please reach out to Mary or I or find your trusted colleague to kind of debrief and process further.
Yeah, I think it was really helpful. I'd never heard of the sort of orchid versus dandelion
I love that.
because I'm currently not practicing because I'm, more in as a educator now. But when I was practicing, I did feel like I experienced a lot of that like sort of secondary traumatic stress. And uh and I guess I didn't have the sort of those healthy outlets at the
Mhm.
time. And so this was really helpful to sort of see sort of some of the resources that we could surround ourselves with to get through those really hard sort of situations and families that we might encounter as a clinician.
You know,
Thank you so much. Yeah, thank you.
I'm going to put, so we didn't include a resource in there. It's a book by Brian Miller. I'll put it in the chat. But it's on managing secondary traumatic stress specifically for the healthcare worker. And I can tell you out of every, being as a sufferer of secondary traumatic stress in the past, I found his book one of the most helpful for helping me see it for what it was and how to deal with it in the future. So I'm going to put it in the chat.
That's wonderful. Thank you.
And I always encourage all of the PT students that are going out to their clinicals. I always say, ask your CIs what their self-care plan is. Ask them to kind of walk you through it because it's something that we don't always model for others in our profession. And so I think it's so important because we want people to stay in our profession, right? We're all very passionate about it and we want people to stay. So it's like, what can we do to continue to support our colleagues and the future workforce as well?
Exactly. So last call for any questions or comments. Feel free to unmute or pop it into the chat for our speakers tonight or today or this morning, depending on where you are. So we have Emma Delaney, who would love a reference list for further reading. Is that something that maybe if you had some references that we could potentially post on our IOPTP website alongside the recording?
Sure. Yeah, we definitely have a too many references. We'll work to get it down a little bit for everyone. We'll curate it a bit more for everybody. But yes, definitely. Yeah, and those resources that I shared, those are like kind of like higher level, good introductions. But yes, Mary and I have another list that we're more than happy to share.
Wonderful. Thank you. All right, so before we hop off, I'm just sticking in that link. Um, Jessica, if you don't mind actually bringing up that first slide.
Sure.
Thank you.
Sec.
So before everyone leaves, I just want to make sure that if you haven't already done so, please use the link that I just put into the chat. Or as Jessica brings this up, you can
Sorry.
also scan the QR code.
Be there one
Sorry.
second. Okay, let's see. It's coming. It's like the long pause. Sorry.
No worries.
Okay.
While you're pausing, I have to say I'm very thrilled that my dog only barked a little bit.
Oh, yeah, it's very
That was
sweet.
good for me.
So yeah, this form is how we'll verify your participation. And for those that complete the form, we will send you a certificate of attendance within the next few days. So today's webinar has been recorded. The recording will be posted on our website and our YouTube channel in the coming days as well. Please feel free to share the link with colleagues who might benefit from the content. So thank you again so much to our speakers, Dr. Barreca and Dr. Swiggum, for their excellent presentation, and to all of you for joining us today for the 11th IOPTP webinar. And we look forward to seeing you at our next event. Thank you, everyone.
Thank you.